Hello, everyone. My name is Dr. Marnie Kramer, and in our lecture for your learning guide, I'm going to review the concepts of hemostasis and allostasis. And these are two terms that you should feel familiar with from your previous coursework, but it is a very important area for us to study when we're thinking about assessing our patients and completing vital signs. So we know that disease disrupts homeostasis, and the body reacts to this disruption through a process called allostasis. So in this course, we're going to help you to understand how this unfolds and how we find these types of signs within our client assessment that these two processes are happening. So when we look at homeostasis, it's the stability of systems that maintain life. So the pH of our blood is extremely important in letting us know what's happening with the body. So for example, somebody who might have gone into cardiac arrest, they might have a very low pH, for example, a pH of 6.8. Where a client that might be experiencing, alkalosis or an increased basic state may have a higher pH. And so you'll learn about pH and arterial blood gases in this course because it really guides how we're going to direct patient care. Homeostasis is also about the concentration of different ions in the extracellular fluid. And so, we know potassium, sodium, calcium, they all play a really important role in terms of not only cellular, health, but also in different aspects of homeostasis within the body. We also look at glucose levels. We're going to talk about patients that have high glucose levels and low glucose levels in this course. When we go into aspects of diabetes, that will mostly be second semester. And of course, arterial oxygen tension. So we need to know how much, arterial oxygen we're carrying in our body because that's going to tell us a lot about client outcomes. So our body adapts as we get sick, and it will change to its external and internal environment. So we look at things such as arterial blood pressure, which is a very advanced way of monitoring blood pressure. We actually put a catheter into an artery and then we attach that through a transducer to monitor, and it tells us directly what's happening in the arterial system. We use more simple types of blood pressure measurement in nursing as you start out, and we'll talk about that in our lecture when we cover non-invasive blood pressure. We also look at heart rate and our body's core temperature as other indicators of how we're adapting to a disease state. And there'll also be evidence of this when we look at the concentration of circulating hormones and how the patient is being impacted in terms of their sleep-wake cycle and also with their energy metabolism. Now, it's important to remember that homeostasis is constantly present, where allostasis is a temporary process and it occurs under stress. Now, hemodynamics are very important because the way that we determine allostasis or the adaptation of our body through a disease process is through hemodynamics. And as you become more involved in your clinical practice, you'll often be asked, is your patient hemodynamically stable? And so all we're asking when we ask nurses that response is, what is their blood pressure? What is their heart rate? And are they oxygenating within their body? So we're going to review a little bit of hemodynamics that you've learned previously. So we know that we have systemic and pulmonary circulation. And when we are circulating blood to our body system, we do this through the arteries. So arteries, here in the red, of course, they supply tissues of the body with nutrient and oxygen-rich blood. And as that oxygen-rich blood goes through the body, it will return through the pulmonary circulation. So when we look at systemic circulation, blood is coming out of here, the down the left atrium, up the left ventricle, and out the aorta to the body. Okay. Now, in pulmonary circulation, we're having venous blood return. So deoxygenated blood is returning to the heart, and that's coming in through the vena cava. And we know that our vena cava is either coming from the top of the body, the superior vena cava, or down through the bottom. And this deoxygenated blood is getting pushed out through the right ventricle into the pulmonary arteries and through the lungs, where it's becoming reoxygenated and coming back into the left atrium. Now, one very important concept when we're talking about hemodynamics is cardiac output and stroke volume. So cardiac output is basically the amount of blood pumped by the ventricle in 1 minute. So any factor affecting the heart rate or the stroke volume, that's the amount of blood that's leaving the heart, will affect a patient's cardiac output. So a normal cardiac output is typically 4 to 8 liters per minute. Now, heart rate is responsive to both sympathetic nervous system and parasympathetic nervous system tone. And we know that heart rate is controlled by the cardiovascular control center in the brain. Stroke volume is the amount of blood ejected from the ventricle with each contraction, and it's determined by the amount of filling or venous return and the force of ventricular contraction or contractility. So I want you to think about, circumstances where you may become nervous or anxious. So most of us will have an increase in our heart rate and our blood pressure. So that will increase our cardiac output to meet our demand. And so we look at a few things that are happening during cardiac output. We look at ventricular volume. So that's how much blood is actually in the ventricles prior to systole. We look to see if there's any increased venous return. So that's adding to our ventricular volume. And we look to see if the body is in a state where it's able to increase its contractility, or the force that the blood is actually ejected from the heart. So when we look at cardiac output, let's say we have a patient that has a heart rate of 60 beats per minute and their stroke volume is 0.1 liters beat per minute. That gives us a cardiac output of 6 liters per minute. Now, when we look at cardiac output, we look at a few different indicators, and the first is cardiac preload. So preload is the volume of blood returned to the heart pre-systole, okay? And it exerts pressure on the ventricular walls. Sometimes we'll also call this filling force. And what happens with preload is as the heart stretches, it generates more force to effectively pump the increased load. And we call this the Frank-Starling mechanism. Okay, so in a healthy heart, when we have more blood coming into the ventricles, it stretches the heart out, and then the heart forcefully contracts that blood out, okay? The reason we say the Frank-Starling mechanism has limits is if a heart becomes damaged, it doesn't have that same stretch and contractility, so blood does not get pushed out the same way it does in a healthy heart. When we increase the preload, we increase the oxygen demand of the myocardium, but it is more oxygen efficient than increasing heart rate, okay? So you have to remember that oxygen gets used anytime the heart is taking on more workload. But it is better to increase preload and have the heart beat that amount of blood out than to have a high heart rate. And when we get into the cardiac section of this course, we'll talk about why cardiac patients often have their heart rate kept under 100 beats per minute. And that is because of oxygen demand. So while preload is the amount of blood in the heart prior to systole, afterload is the pressure that the ventricle must overcome to eject blood into the arteries. So during contraction, the left ventricle must generate more pressure than the aortic diastolic pressure. So it has to actually increase the pressure so that that blood goes out to the body and it doesn't come back into the heart. The pressure that the heart generates to get the blood out must also be great enough to overcome peripheral resistance. So you have to remember that our vascular system in many senses is pressurized because we're always moving blood through. And so when the heart is pushing blood out, it has to be able to overcome the resistance of the entire system. Now, clients that have increased afterload typically have hypertension, okay? And that's why when patients have high blood pressure, we'll give medications to reduce their afterload. Sometimes patients have poor hearts, and we have to decrease the afterload in order to allow that heart to get the blood out into the system, okay? And it's important to note that increased afterload can decrease stroke volume. Now, of course, we have pressures in the systemic and pulmonary circuits. And since the arterial pressure is constantly changing with the cardiac cycle, we often use something called mean arterial pressure, or it's an average. So it lets us know if we are pushing enough blood through our system in order to be able to supply blood to our major organs and, of course, to our brain. So I'll talk about this a little bit more in the lecture. But what a mean arterial pressure is we take the top number, the systolic blood pressure, and then we add it to the diastolic blood pressure, and then we add it to the diastolic blood pressure again, and we divide it by 3, and it gives us an indication or a reading. So basically, all you need to know right now with mean arterial pressure is that we will use this formula to calculate blood pressure in situations where maybe a blood pressure looks like it's too low or too high. So when we're looking overall at allostasis within the body, we look at arterial blood pressure, and mainly we look at the blood pressure that the patient has and the mean arterial pressure, okay? So this is the driving force that circulates blood through our bodies. We look at systemic resistance, so that's the opposition to flow or the friction of blood passing through the vessels. And then we look at any factor in our patients that affects cardiac output or systemic vascular resistance that will ultimately affect their blood pressure. So it's important to remember that cardiac output is determined by heart rate and stroke volume, where stroke volume is influenced by contractility, venous return, and blood volume. And when we look at systemic vascular resistance, it's determined by the arterial diameter, where vasoconstriction increases, systemic vascular resistance, and vasodilation decreases it. So an increase in blood viscosity or thickness also increases systemic vascular resistance. So if all of this is feeling a little overwhelming right now, I just encourage you to become familiar with the terminology, because Chris will re-review all of these concepts when she goes through the perfusion class and when she covers her cardiac content at the end of semester. What we need to think about in our class are the factors that are controlling blood pressure, okay? So we need to keep in mind that cardiac output, especially when it increases with heavy exercise, right, will increase blood pressure. And anytime we get pump failure, so we get a weak pumping action of the heart after a myocardial infarction or heart attack, or if our body's in shock, we're going to have a decreased blood pressure. When we look at vascular resistance, if we have increased resistance in the heart and we have vasoconstriction, we're going to have an increased blood pressure. And if we have decreased resistance or vasodilation, we're going to have a decreased blood pressure. Then we're looking at the volume of blood that's in the heart and in the vascular system. So if we have a patient with a hemorrhage and they're bleeding out, it makes sense they're going to have decreased volume and thereby a decreased blood pressure. Or if they have increased volume, for example, they increase their sodium and water retention, or we give them too much IV fluid, they're going to have an increase in blood pressure. And then we look at the viscosity or the thickness of the blood. Some disease conditions cause an increase in blood viscosity, and polycythemia is a condition I'll teach you about in class 7. And when we get thick blood, we end up having an increased blood pressure. And then finally, we look at the elasticity of arterial walls. So increased rigidity, hardening, in conditions like athero or arteriosclerosis, we all of a sudden have a heart pumping against greater resistance. So really what we're trying to show you in this initial lecture is that blood pressure is more than just taking a measurement in the body. As a nurse, we are thinking about all of these different types of influences because how we treat a high or low blood pressure will depend on what's happening physiologically within the system.